Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. Now, this is the audio version of the past week summaries, which this week were brought to you by our authors Amanda Matthews, Joshua Dodge, Clark Strunk, Rebecca DeFabio, Millie Casse, and Clay Smith. Okay, now the first article, which was titled High Flow or Standard Oxygen in Acute Hypoxemic Respiratory Failure, the SOHO trial out of the New England Journal of Medicine. Now, really, I think high flow nasal cannulas really hit their stride somewhere around COVID, because that's when we really started to use them, especially with the influence of thinking that, oh, hey, maybe we shouldn't be intubating all these patients. And since then, high-flow nasal oxygen has been extremely popular as a way to oxygenate our patients. However, the exact data behind it isn't totally clear. When is it beneficial? When is it not? Are we decreasing mortality? What are we doing with high-flow nasal cannulas? We have seen in past trials that high-flow nasal oxygen was non-inferior to non-invasive ventilation. There were some problems with that trial, of course, but all the same, we see that it's performing pretty well. Now, in this trial, we tried to go a little bit in the other direction in terms of comparison and compare high-flow nasal oxygen instead of to non-invasive, just to a mask, to standard oxygen therapy. Not necessarily providing BiPAP or anything like that, just oxygen. And we want to see, in this case, is it doing better? So this was the SOHO trial, which was conducted in 42 ICUs across France and enrolled about 1,100 patients who were randomly assigned to standard oxygen therapy or high-flow nasal cannula. The patients were enrolled who were admitted to the ICU and had to have a respiratory rate over 25 breaths per minute, a pulmonary infiltrate on their chest X-ray, and a PaO2 to FiO2 ratio less than or equal to 200. So a lot of these patients are going to have kind of an ARDS type picture for them. Now they were going to get high-flow nasal cannula or a standard non-rebreather mask at least 10 liters per minute flow. The goal oxygen saturations were pretty typical, 92 to 96%, and the primary outcome was 28 all-cause mortality, with secondary outcome including intubation at 28 days. And what they found was that the mortality rate between the groups was exactly the same, 14.6%. However, the incidence of intubation was a little bit higher in the standard oxygen therapy group, 48% versus 42%. So there was some benefit there to high-flow nasal cannulas. However, while they do have specific criteria as for why they were intubating these patients, they do not actually say why in each case these patients were intubated. And this actually matters because not all of those criteria were necessarily objective. And so you might give your patient a bit more of a chance when you see them on high-flow nasal cannula already. You think, hey, we're already being quite aggressive. Versus if they're just on a standard mask, you might not think that you're necessarily doing enough. And so when you're not allowed to upgrade to something else, you might actually just intubate that patient. So there's definitely some subjectivity to it here. And some of this matters because there was no significant difference in the number of ventilator-free days. So their claim that it would decrease ICU resources by having less intubations might not be the case because you still have the same total number of people on the vent for the same amount of time. And you could even make the argument, oh, hey, well, at least there's some signal. Maybe it's doing benefit. There's no harm. There's actually 3 times more patients with spontaneous pneumothoraces in the high flow group, which might just be coincidence. But, it sounds a little bit concerning from that perspective if we're going off of speculation on some of the numbers in this study. But I think all of this sort of lends itself towards that you shouldn't necessarily just put everybody on the same type of oxygen therapies, and you should maybe pick and choose. When I say that, though, then we get into the problem of that we don't have very good data to say who to pick and choose for which thing, unfortunately. And it's not altogether that clear that high-flow nasal cannula is really doing anything more than anything else. I would have liked to see some of what patients thought about the 2 different choices. Is it more comfortable to have one over the other? I think that's a fairly reasonable justification for using one type of oxygen over another if your patient is much more comfortable with it, especially since many of these patients had days at a time on oxygen. I think that comfort is important as well. Mortality is probably more important, but I want my patients to be comfortable. So in a spoonful, high-flow nasal cannula does not seem to be saving lives when compared to just standard oxygen therapy. While many are a fan, there seem to be minimal benefits so far over standard oxygen. Okay, then let's skip to the fifth and final article, titled The Impact of Defibrillation Current and Pad Position on Return of Spontaneous Circulation During Refractory Ventricular Fibrillation, out of the journal Resuscitation. Now, I hope everybody remembers the dose VFRCT. This was an important trial which showed us that dual sequential external defibrillation might have quite a bit of benefit for patients that have refractory shockable rhythms. It also showed us that vector change can be an important method as well, switching pads from anterolateral to anterior-posterior, because AP pad placement might have better vectors for depolarizing the entire heart. Now, what these authors wanted to know was whether or not pad placement and the amount of current that actually gets through your heart is what's going to be important. How does that play a role in the success of these defibrillations? What the authors saw was that AP pad placement was significantly associated with a greater amount of current that's going to go through there and significantly lower impedance compared with anterolateral pad placement. With, as we know, the AP pad placement had a significant association with ROSC from the dose VF trial, of course, which all of this data came from. This is just a reanalysis of the dose VF data. So what we see here that AP pad placement has sort of better numbers, better current, lower impedance. But if you just look at the current and the impedance, you do not see an association with better ROSC. So it's really the pad placement that seems to matter. And this aligns with previous data, which shows no clear correlation between current and successful shock either. So perhaps the path of the current is what's the most important thing. And that would explain how vector change and dual sequential external defibrillation are really working. It's not that you're applying more current because it's a more efficacious way to apply current. It's the fact that you're applying current to the correct location, that you're actually depolarizing potentially the entire heart. Whereas with anterolateral placement, you might be preferentially defibrillating more the anterior side of the heart and not necessarily getting all the walls that you want to. And how is this reflected in the guidelines? Well, the AHA still endorses either positioning, while the European Society of Cardiology and ILCOR actually still recommend anterolateral pad placement, but this is really due to the ease of application, and not necessarily because it's better. I don't think we have enough data yet to say definitively that anterior-posterior pad placement is better, but it seems that we're going in that direction. So whenever you can, whenever it's convenient, perhaps anterior-posterior pad placement is the better way to go. But, this is still reanalysis of a slightly getting older trial at this point, and more data is going to be needed. In a spoonful, what seems to matter most is not necessarily the current that gets through your chest, but the pad position and where that current goes. All this from a reanalysis of the dose VF trial. Okay, that's all the 5 articles from this week. Let's do a quick wrap up of everything we talked about. From the first article, high-flow nasal cannula did not improve mortality in this large ICU trial, but slightly decreased rates of intubation without a decrease in ventilator-free days. So the net benefit seems to be essentially nil, especially with the decision to intubate being subjective in some components. Then from the 5th article, pad position might be the most important factor, rather than how much current is getting through your chest during a defibrillation. Now, if you were hearing this right now, then you were not a part of the members feed, and so you missed 3 articles from this past week. What did you miss? We talked about emergency department boarding and how that's associated with decompensation. We talked about, hey, what if we gave unfractionated heparin upfront pre-hospital for STEMI patients? And then finally, a systematic review and meta-analysis comparing resuscitative thoracotomies against Reboa. Links to all the original articles can be found at journalpede.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.